So we'll go ahead and talk about some acetabular fractures and some higher energy injuries. I'll say this up front. I've been using CurvaFix for several years now, and I think it's very, as has been discussed by our previous presenters, it's extremely useful in a variety of different injury patterns and circumstances and around the pelvis and acetabulum. I've trended more towards using it in fragility fractures recently, but it's extremely valuable as well for the bag of tools and tricks for treating acetabular fractures. So we'll advance to the next slide. Disclosures next. So this case, first case I'll present, this was a 24-year-old male who was involved in a motor vehicle accident. He also had a right femur injury, left olecranon, a right distal radius. Next. So just some injury films. He basically had a higher energy right acetabular fracture. It was a transverse posterior wall variety. You can see his femur fracture there that was treated the day of injury with some early total care. Next. So this is the classic pre-reduction CT obtained by the emergency room physicians, which just shows some of the pattern of the injury there, the transverse posterior wall nature of the injury. The last slide on the right shows after we've treated his femoral fracture with nailing, and he's reduced in some traction for later definitive care of his acetabular fracture. Next. So I think we've had already some really excellent slides showing the versatility and the usefulness of this CurvaFix implant. And traditionally, the traditional fixation pathways, I think Samir did a good job of talking about posterior column. We all know about the anterior column, how you basically have to be really sort of, straight on with a good, perfect trajectory if you're going to try to use a straight implant. And that's kind of been the historic implant that's been used in these circumstances. But for all the reasons previously discussed, this CurvaFix implant is really, I think, performs very well in these circumstances. I think one thing I would like to mention is it's almost really beneficial to have sort of an off-axis start point, if you will. The forgiveness for the start point is, I think, a little greater, and what that does is actually allows your implant to curve even more, and you end up with this fixed curve. And we talked about the bent axle and removing a broken or a bent femoral nail. And, you really have that additional fixation, the more curves you can induce into that implant itself. So we see some shots here with a starting point, an angle jaw clamp on the anterior column component of this transverse fracture. So we have the starting guide wire, then you use the opening reamer for this system. There's the metal guide tube that's inserted that sort of stabilizes your guide wire as you can snake it across, and it's got that curved tip that you can turn. It's been discussed by our presenters. You can direct it with little tiny taps as you change views, and you can get it all the way over to the symphysis. One thing I would like to note in this particular circumstance is a lot of people have asked me previously if you can generate compression with this implant, and I've been able to do that several times. I think was a little technically difficult with some of the original versions of the instrumentation, but I would try to basically tap that guide wire out and to get to a point where I could ream, as I think you can see in that bottom fluoro. I would try to get it out so I could basically end my implant with the threads in some potential cortical bone there to generate some sort of compression. And it's been successful when you can do that. I think with some of the advancements in the instrumentation, like drill tip guide wires, that'll be even easier to do. So this was an earlier on case, and so that's actually the 9.5 implant. So the bigger version going in. Next slide. So you can see there kind of going into its final position, and I think you'd see in the fluoro that the threads sort of, if you can get the length just right, you can generate some compression as those, big aggressive threads sort of grab into some of the cortical bone near the symphysis. Next slide. So after going ahead and repairing the, the posterior injury, stabilizing the posterior column, and then repairing the, posterior wall, this is what we sort of have with our final fluoro shots. And it shows, a nice curve on that implant, nice stability. It's I think extremely useful, even in the higher energy acetabular fractures. If you're not, obviously this is not a pure, percutaneous case. In this example, you're open, you're putting a clamp on, your displaced components of your fractures to reduce them, but this can still be used in this circumstance to stabilize such an injury with good results, and I think excellent stability. Next. So these were post-op images for this case. I think it shows, a nice example of that anterior column screw. Again, that's the bigger one. Nowadays, I'll use the 7.5 variant, as Nick was talking about. Next. So here's this patient ended up getting a post-op CT for other reasons, but that shows some of the positions of the screw. Next. And this guy actually had 2-year follow-up. Just recently, he was doing very well and had a little bit of HO, but was back doing everything he wanted to do with no complaints, and sort of a successful outcome from one of the first cases that I treated high energy acetabular fracture with one of the CurvaFix implants.